I'm delighted to introduce our next presenter. This is Dr. Robert Arnold. He is the Gerald J. and Dorothy R. Friedman Chair in Palliative Care, Professor and Vice Chair for Professional Development in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Arnold is clinically active in palliative care and has published on end-of-life care, hospice and palliative care, doctor-patient communication, and ethics education. He, along with Tony Back and James Tulsky, co-founded VitalTalk, the premier communication training organization for clinicians caring for patients with serious illness. His current research interests focus on using technology to develop educational interventions to improve communication and better understanding how ethical precepts are operationalized in clinical practice. Thanks so much, Dr. Arnold.
No problem. I'm really glad to be here. I'm glad to be right after lunch because hopefully you guys are still eating and you're to the dessert part, which is the best part of lunch. I'm going to be talking about decision-making for patients who lack capacity. By the end of this, I hopefully will have helped you answer these questions. What's a surrogate? Or synonymously, for our points of view, a healthcare proxy? What are the ethical principles guiding surrogate decision-making? What do surrogates tell us about the experience of being a decision-making for their loved one? And what communication techniques can you use to help surrogates make decisions that cause them less stress and anxiety and also are ethically justifiable? I'd like you to take 20 seconds and write down your questions. That you can't put them in the chat, but write down your questions on a piece of paper next to you or on your phone so that you can look and make sure by the end of this session that I've either answered them or you can ask them on your own. So just take 15 seconds. Okay. My disclosures are that I'm an editor for Up to Date on the palliative care section, and I'm on the board of VitalTalk, which Lauren had talked about at the beginning. I also should give you some warnings and caveats. I'm not a lawyer, and so many of the things regarding surrogate decision-making are often legal, and depending on whether you're New Jersey or Pennsylvania or New York, they're different. So if they're legal questions, you shouldn't trust me. You should talk to your hospital lawyer. I'm going to focus on issues regarding the ethics and the communications related to talking to surrogates. It's important because a 2010 study showed that 42% of people who required decision-making in the last weeks of life, only 30% of them had capacity. 70% of them didn't have capacity. And so it's very common that you're going to not go to the patient to discuss these issues. You're going to go to their surrogate to discuss these issues. When thinking about surrogates, this side sort of gives you the criteria for choosing a surrogate. Gives you the criteria for deciding that someone has or doesn't have capacity. Now, I need to remind you that capacity is decision specific, so you can have capacity for some decisions and not other decisions. It's also time specific because you can be delirious and not have capacity today, and 3 days from now have capacity. The criteria that generally get invoked are that you need to understand one situation and its consequences. You need to be able to express and communicate a preference. And you need to, what I would say, give a non-irrational reason for your decision. That is, you don't have to give a reason that other people will agree with, And the clinicians don't think it has to be rational. I would argue it just can't be irrational. Now, if the patient lacks capacity, it doesn't mean that the doctors or nurses can do what they want to do. What it means is that the patient's decision isn't determinative. And in those situations, you need to go to a surrogate. So if there's loss of decision making, you need to go to a surrogate. And there are a variety of different ways to figure out who the surrogate should be. One is the surrogate can be directed by a patient, either an advance directive or by filling out a healthcare proxy form in New York. If they haven't done that, you go to default surrogate laws. Many states have an order. And if you don't have that, you often go and need to go to courts to get a guardianship named. Let's go through each of those. So say the patient lacks capacity. You first would look to see if there's a patient identified surrogate. That means the patient has said, I want this person to serve as my proxy. If the patient has identified a surrogate, that takes precedence over everything else. Now, some people say, some patients have filled out both a proxy and they filled out a living will or an advance directive. Which should I listen to? What the empirical data would say is that most patients want you to listen to their surrogate or their proxy, not to their living will. In two large-scale studies, 2/3 of people said, listen, defer decision-making, even if I have an advance directive, to what my surrogate would say, because I trust them to make the decision for me in real time. Let's say the patient hasn't designated a proxy. Now, in some cases, there's already been a court-appointed guardian. That person would be next on the list because it's already been adjudicated within the legal system. If that's not the case, you would go to the next of kin. And every state is a little bit different about their order, but it's often the spouse or the partner, the adult children, the parents, adult siblings, other adult relatives, or unrelated friends if no one has been appointed by the patient. It gets complicated if people have second marriages and adult children from first marriages. And so I would refer you to your hospital policy or your hospital counsel. I also want to be clear that the state laws about this don't match exactly what the ethical principles are. From an ethics point of view, the person who should be the guardian, the person who should be the surrogate is the person who best knows what the patient would have wanted and who cares about the patient the most. When you get down to other adult relatives who haven't seen the patient for years or decades, it is often the case from an ethical point of view that a very close, unrelated friend is a better surrogate than their third cousin who they haven't seen in 10 years. In those cases, what ethics would tell you to do and what the law tells you to do may differ. What I will often do in those cases is have the friends be at meetings with the adult relatives because they can often provide information about the patient that the adult relative who isn't very close may not know. Next, we're going to go to, we have a surrogate. what are the ethical principles about how decisions should be made? The first thing is, has the patient previously stated a wish, and have they written it down? Because if they've written it down, they've wanted everyone to know that these are their values. Often that's called a living will or an advance directive, and it's a legal document expressing your wishes about the medical treatment you would want if you can't make decisions for yourself. There are a number of different kinds of living wills. There are a number of living wills that are available on the internet. Rebecca Sidori has one of the best. They're often ones that come often from legal counsels that people go get a regular will. Their lawyers often will have a form for a living will. Many of the living wills that you may see, I would argue, are not very helpful because they say things like, if the patient is irreversibly and terminally ill and will die regardless of what you do, these are what my wishes are. I would just point out that if you're irreversibly and terminally ill and you will die regardless of what the doctors do, your wishes sort of don't matter a lot because it's not going to change things. Or the living will say, I want CPR, ventilators, feeding tubes, and it's a checklist, which if you go over with your lawyer, doesn't tell you very much about what the context is of those decisions. In many cases, in fact, those kinds of living wills need the patient surrogate to be involved to try to help interpret them, because given the medical scenario, it requires interpretation to know what should or should not be done. More sophisticated living wills will, in fact, ask the patient, should I listen to what you say or should I listen to what your surrogates say? And as I pointed out earlier, 2/3 of the time people say, listen to what my surrogate says. Now, given that only about 1/3 of people have written living wills, even if they're above 65, the ethical principles that often get used are substituted judgment. That's what would your dad say if your dad was sitting here? That is, I'm asking the surrogates to try to figure out what their loved one would want. So the surrogate's job is to substitute not what they want, to put in what their patient would want if the patient was sitting here and could hear what you're saying. If some families don't know, and so the next ethical principle is best interest, which is more, given most people, what do we think is in your loved one's best interest? Substituted judgment is more personalized because it tries to guess, given your loved one's values, what they would say. Best interest is less personalized because it's what most people would think, or what a reasonable person would think is in their best interest. I will point out that while those are the two big ethical principles, it doesn't mean that a surrogate can't also consider how they feel about it. Because using substituted judgment, what I as a patient may care the most about is the fact that my children can live with the decision. And so my substituted judgment wants my children to take into consideration what would be important to them because I, as the patient, care about them. So that's the law and that's the philosophy. Now let's look at what surrogates say it's like to be the person who's being asked these questions. What surrogates say to us is in the title of this paper that Yael Schenker from the University of Pittsburgh and I wrote called, I don't want to be the one saying we should just let him die. interpersonal tensions experienced by surrogate decision makers in the ICU. In this study, we interviewed surrogates to get their opinion about what it was like to be a surrogate. And this is what they told us. I'm going to read the first quote above the line right here. I think we're both on the same path, especially now. It's just, like it's your mom. You want her around forever if you could have her around forever. And she has some of her wishes, like 4 days on a ventilator with no improvement, which there has been. I have to sign a consent to take her off, and whatever happens, happens. But just knowing that I would be signing her death sentence, more or less, that's hard. And I know and I understand she wouldn't want to live like that. So I'm on the same path, but there's still an emotional aspect of it. Surrogate said, you want to give her a chance, and that's all. And why even now they talk about trach and dialysis and things, and you think, well, I'm not sure if she'd want that, but why not give her a chance? I don't know. That's what I struggle with. That's the struggle. And given this, it's no surprise that so many surrogates have either anxiety or post-traumatic stress syndromes after they served as a surrogate for their loved one. And in fact, what the data shows is regardless of the decision they make, over half of surrogates have psychological sequelae after these decisions. Similarly, if you look at the pediatric world, what the pediatric world that looks at how parents make these decisions show us is that there's a different theory than best interests and surrogate decision making. How parents make these decisions is called the good parent theory. They want to be viewed as a good parent, regardless of what happens. Because remember, they can't imagine what their 2-year-old kid would want. Their 2-year-old kid has never had capacity and so can't make a decision. I think that's really important for us to remember when we are talking to wives and children. Because in my experience, the struggle for many surrogates is, what does it mean to be a good son whose mom is dying in the hospital? What does it mean to be a good wife? And as we help them think through these decisions, we need to continually remind ourselves that they're doing the best they can. And it's why praising them for doing the best they can is so important, because they're struggling with what it means to be a good loved one as the patient is dying. So we spent a fair amount of time talking about the law, philosophy, and how surrogates face these decisions. We're going to spend the last 25 minutes talking about how to have conversations with surrogates. I think when you first sit down with them, you need to find out what they know about what's going on with their loved one. Now, they're meeting so many people, particularly if they're in the hospital, that I like to point out to them that I've done my work. So I'm not just asking them because I'm clueless. I'm asking them because I don't want to waste their time going over things they've already been told. So I'll say, I've already reviewed your loved one's chart and spoke to the other clinicians. I don't want to sort of tell you things that people have already talked to you about. So tell me what the other clinicians have told you about your mom's condition. That's my way of finding out what they know, because if they're already informed, I don't have to go over the information again. And if they have misconceptions, it helps tie what I'm going to say to their misconceptions. I also currently often will say, what does it say when you look at the internet? Because most of us, if we're not sure and we have uncertainty, we go to either AI or Google to tell us what the truth is. And I want to know what they've read on the internet because, again, if I don't know what they know, I can't help add information in a way that they'll understand it. And my goal when I talk to surrogates is to make sure that they understand what I'm saying. My goal when I give information isn't just to talk, it's to tell them in a way that they will be able to go home that night and tell the rest of the family or the other people who care about the patient the information. Now, what's difficult about this is we know that most of us can only remember 3 to 5 things. We remember less than 25% of what we were told verbally. It's less if we're stressed and we're anxious. So I need to think very carefully about the core things that I want the surrogate to hear. What I'll call those are a headline. And that's 1 to 2 sentences that give the take-home message of what's wrong and what does it mean. That's very different than the way we talk to each other, where we give long paragraph or page-long descriptions of the medical facts. For most families, I'm not going to start my conversation that way. I'm going to start with a headline because that's what I want them to remember. I also am going to give it in understandable 5th grade language. There were a couple articles from the JAMA journals that showed that 50% of Americans don't know what metastases are. People are easily confused by the medical information. So I need to give the information in a way that they will understand them. Now, it's part of the reason that I say to people, what have the doctors told you? Because if they start telling me that the doctor said, that he had ARDS, then I'm going to say, oh, it sounds like you have some medical expertise, and I can upgrade the language that I use. In general, though, it's best to use 5th grade language. It's also best to think about if you're disagreeing with what the family has heard, to use the word and. That is, if I give a headline and the family says, well, that's what they told us last time, I need to say, I hear ya. And so it's hard to believe what we're saying. The word and allows you to just list what you're saying with what they're saying. If you use the word but, what you're really doing is saying, I don't believe what you're saying. So when you say, I know you want him to get better, but he's really sick, what you're doing is discounting what they're saying. So say you give a headline. The way that you know that your headline worked and that they heard your headline is that you will get a strong emotion. I often tell learners that if I don't get a strong emotion when I give a headline, particularly if it's bad or serious news, it means that I didn't give a good headline. To give a good headline is that I'm telling the family or surrogate something's going to happen that they don't want to have happen. And emotions are the way we know sadness, frustration, anger, grief, that they heard my headline. Now, the interesting thing about emotions is that when you are emotional, you often don't listen very well. When you're emotional, you often talk about what matters most or what's behind what you've heard. And that when you're emotional, your cerebral cortex is a part of your brain that does reasoning, isn't firing when you look at functional MRIs. What helps people when families or surrogates express emotion is for you to verbalize empathy, for you to try to help them see that you know what they're going through and you're going to walk that path with them. It's particularly important to do that after you've given really serious news. The easiest way to do that is to just name the emotion that you're seeing. So you would say, this isn't what you wanted to hear, or I can see this is frustrating. Or to show that you're trying to understand what they're saying so that you get it right. Here, saying something like, I can't imagine what you're going through, is a way to show that you're trying to imagine what they're going through. The point here is to try to join with them so that they see that you understand how upsetting, distressing, or sad this is. We have an acronym called NURSE, N-U-R, respect statements, S, support statements, and E, explore statements. I think the first two, particularly at the beginning, will get you 80% of the way there, so I would focus on that. I would also say that the more your empathic statement can reflect back what the person has really said, the better it will land. It has to sound genuine and that you're really trying to understand what they're going through. Now, sometimes the family will ask a question after you've given serious news, like, how could this happen? He was so healthy when he came into the hospital. And I think a place where we get stuck as clinicians is we answer the question. I will tell you that typically, after giving serious news, they're not really interested in the answer to the question. They're interested in the emotion that's behind the question. So if a family said, how could he get so sick? He was healthy a week ago. They don't want to hear about sepsis and how people, when they're septic, their blood pressure gets low and they develop renal failure and acute respiratory distress syndrome. What they're really saying is, oh my God, this is too quick. I'm having trouble getting my head around it. Or this is such a shock. I can't imagine that he was so healthy a week ago. So it's really important when you get asked questions, particularly if they're after you give serious news, to respond to the emotion behind the question rather than just respond factually to the question. It's also important when families don't get it to not just keep saying the same thing over and over. This is like this orange who thinks it's a lemon. Too often, when the family doesn't get it because they're in denial, we think our job is to help or force them to get it. The problem is when we try to do that, the conversation usually goes bad. Because denial is a psychological defense mechanism that protects us when it's too emotionally difficult to hear news. And so when the family says, I can't believe that, he's going to get better, you're continually saying, but I don't think he will. It's just going to get them to hold on more strongly to, he's going to get better. In these cases, what you need to try to do is attend to the emotions and make it safer psychologically for them to hear the information. I also think it's really important when you're trying to figure out what to do to make sure that you ask surrogates the right question. as we talked about at the beginning, the reason we talk to surrogates is because they know what the patient might have wanted, and the surrogate's job is to reflect the patient's values and preferences. And so your questions need to pull the patient into the room. Questions such as, had your mom ever spoken to you about what if she got sicker? Has anybody else been sick like this? What did your mom say about that? If your mom could hear what we're saying about her medical condition, what would be most important looking forward? If your mom could hear what we're saying, what would she want to avoid? What would be important that she'd say, I don't want to go through that? The key here is to focus on the patient's wishes. What sometimes I hear people say is, what do you want us to do? And asking the surrogate what they want you to do places the burden on the surrogate rather than asking the surrogate to do what ethically and legally we want them to do, which is to represent the patient. A great example of this is the question, what else? So after I say, hey, if your mom could hear what we were saying, what would be most important looking forward? And the surrogate gives an answer, you should then say, what else would be important? That is, you should continually say what else to give the family the opportunity to tell you, the surrogate to give you the opportunity to tell you all the values that are important to the patient. I'm going to show an example of this. I want you to watch this so that you can help me see what this doctor did well in talking to a surrogate. Oh, let's see if I can get this. Thank you so much. So in this video, since it doesn't play, in this video, what the doctor said, the doctor was talking to a patient who was intubated, and the doctor said, now we need to talk about what comes next. And the patient said, well, I don't want you to pull the tube. And the doctor said, if your mom was sitting here, what would your mom say? And the surrogate said, oh, if my mom could hear what was going on, she'd say, don't keep me on those machines. I don't want to live the rest of my life on those machines. She would be mad that I'd even put her on the machines to begin with. I think the thing that's important here is that the clinician didn't get thrown off balance when the surrogate made an emotional statement, which is, I don't want you to come off the machines. The doctor asked, what would your mom think? Now, I also want to tell you that after you have a clear sense of what the patient's values are, it's often okay to suggest a recommendation. Too often, I think, we ask surrogates what they want to do, and we make them feel like they're making a decision. And what we know is that's very hard for people to make suggestions. And in fact, in a study at UCSF, they found while 55% wanted to have the final control, they still wanted to hear from the doctor what the doctor thought. and 45% wanted to share control equally with the physicians. The only way to know what your surrogate wants is to say, would it be okay if I make a suggestion given what you've told me is important? When you make a suggestion, make sure that you focus on what you're going to do for the patient, because otherwise it feels like you're abandoning the patient. Be clear to show why your recommendations tie to the values that the surrogate has given you. And I would urge you not to offer or be clear about what you don't think you should do because they don't meet the patient's values. If the surrogate disagrees, be curious, not judgmental. Say, what did I get wrong? I want to make sure that we are respectful of you and your loved one. And what I'll often say is my primary goal is to make sure that 6 months from now, you look back and you can say, I did the best for my husband or wife or mom or dad. Some people will say that they're hoping for a miracle. This is an advertisement from a cancer center. And what I would tell you is if your surrogates talk about a miracle, it means that they know how sick the patient is. And you can join with them on hoping for a miracle and begin to talk to them about miracles are miracles. I wonder if we're able to plan for what if we don't get what we're hoping for. Don't say things like miracles are unlikely, because that by definition is a miracle. Don't rain on their miracle. We can both plan for the future and hope for a miracle. I wanted to leave you with a free app that you can use called Vital Talk Tips, which is on both Android and Apple app stores. You can download it. It gives many sort of helpful hints about how to have these conversations with surrogates as well as with patients. And if you want the slides, you should feel free to email me at robert.arnold@mssm.edu. I'll leave this up, and I think we have time for some questions. So I'm getting paid by questions. So if you put questions in the chat, then the host will read them.
Thanks so much, Dr. Arnold. There's a few questions in the chat. Two of them are a little bit similar, so we'll maybe start with those. The first is, how do you approach a situation where a surrogate acknowledges that the patient may not be okay with an intervention or quality of life, but feels unable to make that decision emotionally? And the other one is kind of similar. What do you do when surrogates aren't using substituted judgment and are instead saying that they want to keep their family member alive?
So I get curious and not. First of all, I get curious. I say, tell me what your dad would say. The other is I have sympathy for them. And so I attend to their emotion. And I say, it sounds like it's just impossible. Even though you know your dad wouldn't want this, it feels like, oh my God, how can anyone ask me to make that decision? Then I'm more than willing to make decisions. I say, I don't want to ask you to make that decision. I'm the doctor. I get paid to be a doctor. Given what you've said your dad would say, would it be okay if I tell you what I think we should do? That is, my job is to hold their guilt and sadness, given that I know what their loved one would say.
Makes sense. Thank you. The other questions that we have here is, what do you think are the common pitfalls that happen when learners are kind of using nurse statements for the first time?
Well, I think the common pitfalls is, one, it's what's called the uncanny valley. They're thinking so hard about what to say that they sound like the AT&T customer service person who I always want to kill when they say, I can see this is really disturbing. They sound so fake and so artificial. And some of that is just, it's the first time they've done it. They need to practice saying them, and they need to practice saying them in ways that sound genuine to them. And some of that is just practice. I often say, oh my God, that sucks. I can say that. Other people can't say it. You need to say things that feel genuine to you. That's the most important thing. The other thing that people do is that they try to stack empathic statements. Like they say, oh, I can see you're upset. This is so hard. I want you to know that we'll be there with you. And it's like they're just checking boxes. This is more like tennis. Just hit the ball once, make one empathic statement, stop, and give the family time to respond.
And what about, we have a question, it's a little similar to the first ones, but I think different enough that kind of a different answer, but how do you approach surrogates who only want to hear positive information or news, who are saying, I don't even want to hear about negatives?
So I'd say, oh, sounds like you've heard a lot of negatives from other people and it's hard. I'm going to reflect back emotions. What they're really saying is, I'm too sad and overwhelmed. And if I don't need to say anything today, I'll say, I hear you. All you've heard is bad news. And hearing more bad news it's just more than you can take for today. If I have to make a decision today, I'll negotiate it. I'll say, it sounds like you don't want to hear any more serious news. And yet I'm feeling stuck because we have to make some decisions. Remember, they're doing the best they can. Forcing them to hear things that they're not ready to hear will just make them not build a relationship with you. And it's almost always more important to give it time and try again tomorrow than to push them to make a decision they're not ready to make.
Thank you so much, Dr. Arnold. We really appreciate you coming on.
No worries. This was fun. If people, again, want the slides, if you send me an email, I would particularly love to hear if there's one thing from this talk that you will try to do differently based on the talk. If you tell me that, I'll always send you the slides. Or if you tell me something that would have made the talk, 10% better, I also love to hear that feedback, because if I get asked to do it again, I'll want to do a better job next year. Thank you so much.